Um, Good morning, everybody. Who are the doctors, delegates who have logged in for our session of Dr. Sridhar Ganapathy on our website www.alembicew.com. Now, I would hand over the session to Dr. Dinesh Patil. He will introduce our esteemed speaker for the day. Dr. Dinesh.
Thank you, Sonali. Good morning, dear doctors. Dr. Dinesh, welcome you all on behalf of Alembic Pharmaceutical to this Engage with Expert Pediatric Forum scientific program. Today, we have our eminent speaker with us, Dr. Sridhar Ganapathy. Sir has done his MD in pediatrics. He is a senior pediatric consultant at Srimati Sushilaben and Sri Kikabhai Cardiac Care Center. Sir is awarded with mini fellowship in pediatric sleep medicine from Sydney Children's Hospital, Australia. Sir is also medical director at Janani Children's Hospital. Today, he will going to deliver a talk on obstructive sleep apnea, clues in the oral cavity and oromyofacial therapy for management. Now, I hand over session to Dr. Sridhar Ganapathy. Sir, please start the session.
Thank you so much, Dinesh. Thank you, Sonali. It's a pleasure to be again online on a Sunday afternoon. Hi, everyone. Good afternoon. I know you all must be lazing around at home on the Sunday afternoon with Corona all around you. And I thought this is a pretty good session to take because it's quite boring to listen to the same constipation, the diarrhea, the probiotics that I've been doing for so long. And I thought sleep is something that we tend to neglect and where there isn't much of education. In fact, we are educated in everything except sleep. So I'm going to be first giving you a warm-up session on sleep and then have a case-based discussion on just one single case on the importance of the nasomaxillary unit. And towards the end, I'll be showing a pictorial representation of all the clues that should warn you of an impending sleep disordered breathing. I think most of us have experienced this during a lecture, even though the lecture might have been very interesting. And we have struggled to keep our eyes open. And it could even go on to this extent, where you make the most of an effort and still it's just not possible for you to keep awake. This is called sleep debt. And this is something very scary because you tend to get these micro sleeps. And if you're driving a vehicle, for example, and you get your micro sleep, you're bound to create an accident. And it's something that's extremely scary. Also, during our undergraduate and postgraduate time, I'm quite sure we used to study during the extended hours, and most of us would be studying late night. And what we need to understand is memory is always related to sleep. And if your sleep is not good, then memory is also not good. So it's no point studying late in the night because it is not retained. So this is another thing that we need to understand. And this is usually the rescue that we have for all our sleep disorders, in the sense that the ones with hypersomnia, especially when you feel very sleepy, be it in the morning, be it in the afternoon, be it in the evening, we look out for our cup of coffee. And I mentioned it as kapi there. Being a South Indian, we call it kapi. We make the strong decoction, the coffee. And this is something that keeps us awake for a short period of time. But we need to understand the mechanism of action of coffee. What happens is, if you are not sleeping adequately in the body, you have two mechanisms that cause sleep. One is the buildup of somnogens, and one very important somnogen that builds up in the body is adenosine. So it starts building up right from the time you wake up, and by almost 9 in the night has built up to quite a critical level. The same way is the other mechanism, that is melatonin. That is, as it becomes dark, there is melatonin secretion which goes on going up. And when the melatonin peaks and the adenosine peaks, that's the time you feel, yes, I need to sleep. And these sleep cycles come in 90 to 120 minute cycles. And what happens is, when you take coffee, the caffeine blocks the receptor where adenosine goes and sits and makes you very sleepy and groggy. So if you take caffeine, what happens is it's a temporary phenomenon. Temporary, what I mean is it blocks the adenosine temporarily. So even a glass of coffee, say after 2 in the afternoon, can have a bad effect on your sleep late evening, late night. Please understand this. So it blocks adenosine, but it doesn't get rid of the adenosine. So the buildup of the somnogen adenosine continues. So when there is a buildup of adenosine, so the effects of adenosine and the side effects of caffeine both work together. So you're irritable. Caffeine is a stimulant. It can have an effect on your cardiovascular system also. So you have a double whammy. That is, you have adenosine working in excess once the caffeine effect goes, and caffeine with its hyperactivity and tremulousness and tachycardia and headache, being a vasodilator, you can have all the other effects of caffeine. So the next time you take coffee, to keep yourself awake, understand the collateral effects of caffeine. This is what I was trying to tell you right in the beginning, that we are educated in everything. So we have educational classes on nutrition, on drug abuse, on sex education. We have everything possible, but I don't think we were ever taught sleep during our undergraduate or postgraduate period. It was only in 2004 when I went to Australia and I learned a little bit of sleep medicine under Dr. Arthur Teng in Sydney Children's Hospital that I became aware of the importance of sleep. So it was almost from 89 when I passed out till 2004, totally ignorant about sleep. And since 2004, I've been trying to create awareness in sleep, but I'm still, I think, at the beginning of sleep. And this was a very interesting questionnaire that I gave all the residents in a medical college. I don't want to name the medical college. And I asked them to prioritize the 3 things. So you had Wi-Fi, food, and sleep. And the answers that we got was almost 95% had Wi-Fi as the top priority. 5% has food, but sleep was always last on the list. So you can understand that the importance given to sleep. And we need to understand today that 8 hours in a day is the minimum amount of time that we spend in the bed. So if we spend 8 hours in bed, it means sleep is important. Out of 24 hours, 8 hours you are spending in bed. So sleep has to have something much more than sleeping means. So there was a time when we were told you need to sleep, not to sleep over your problems, but now we are taught after doing sleep medicine that you need to sleep over your problems, because the better you sleep, the better your performance, the better your memory, the better your cognition, the lesser the irritability. And there are so many things that are affected by sleep. And the next few slides, I'm going to show you how sleep is so important and how it is restorative. So sleep matters. So what is sleep? Sleep is totally a restorative phenomenon. Restorative, this is a time when there is neuronal plasticity and you need this restorative capability. Cleansing, you have a glymphatic system in the brain which is most active when you sleep. So proteins like beta amyloid, which are linked to Alzheimer's, are cleaned up. Memory, both declarative and performance. So the next time you keep awake and try to read something, remember, you may not be able to perform. You may not remember also doing it at the last minute and in the last hours. Your concentration, your cognition. So you get better IQ if you sleep well. And your mood. And we all know about this, that the day your emergency goes bad and you have not slept, the next day you're going to be in a foul mood in the OPD, and small things are going to be disturbing you. And a number of psychiatric disorders, they all start off with a sleep disorder. So it's extremely important for you to understand that sleep is a very interrelated thing, and there is so much to do with a restorative phenomena. And even performance. If you sleep well, the next day you perform better, you're more creative, And the chances of you committing accidents, like I told you about the micro sleeps because of sleep debt, you don't do that. And you need to understand that this sleep debt, because I see a lot of people who tell me, "Are exam ho jane do, then I will sleep and sleep." And by the weekend is meant basically for sleeping. You cannot get rid of sleep debt by trying to sleep in the weekend. And the most important thing today in the corona period is sleep and immunity. You need not only good diet, you need not only good nutrition, you need not only immune boosters, but you require good sleep. So one of the best ways to boost up immunity is sleep. And that is the reason when you get high fever and when you are sick, you tend to sleep more because it's the body's way of building up immunity. Also, a lot of inflammatory markers like the TNF and the interleukins also predispose you to sleep because they are somnogens. Sleep and its effect on the endocrine system. We know for sure that if you don't sleep, cortisol goes up. Growth hormone basically comes when you get to sleep in the non-REM part, that is the first and second phase of sleep. And that is the main reason when you get rid of your adenotonsillar hypertrophy, the surgeon removes it and there is a sudden growth spurt. That is basically because the growth hormone that was not coming out has suddenly started to come out. And it's not the control of infection. And we also know that the ghrelin-leptin cycle that is concerned with appetite and satiety is also affected by sleep, and that is why there is a tendency to obesity. And last but not the least, insulin resistance. So you know for sure that if you don't sleep well, you are also going to be in a pre-diabetic state. So there is obesity, there is stress hormones coming out into the open, there is growth hormone, which is not secreted if you don't sleep well, especially the first part of sleep, and you have insulin resistance. Let me show you some timeline on sleep. So it was in 1976 that the concept of pediatric obstructive sleep apnea hit the medicine circle. It was in 1995 that positive airway pressure, wherein they found that if you have a vacuum cleaner and you put the circuit the other way around and you generate positive airway pressure with it, you could have a means of keeping the airway open, and this was called as CPAP, and it was introduced for pediatric OSA. The problem was getting a mask that was custom made and which could fit well on your face, because half the problems was on the leaks and the effect on the nose and the eyes. In 2001, we suddenly realized that yes, we do have a pediatric OSA, but it's totally different from the adult OSA, that there is more arousal in the pediatric OSA, and we have a subset called an obstructive hypoventilation. And in 2004, we realized that adenotonsillectomy is not just the cure for OSA. There are limitations that in spite of doing an adenotonsillectomy, there is a recurrence of OSA, and there is a persistence of OSA in many individuals. And we did see that adenotonsillar hypertrophy was usually in the initial phase, that is up to 11 or 12 years of age, where the lymphoid tissue grows actively. And after that, it was usually obesity that was the cause of OSA, even in the pediatric age group. And it was in 2011, because even the dentistry, the dentists also started realizing that they have to be airway centric. So that is why now we know that the pulmonologist, the ENT, and the dentist, they all form a common group, which is airway centric, and orthodontics came into play because we understood that it could be the mandible being pushed behind, the maxilla, which was narrow, and that if we could have a maxillary extension, a mandibular maxillary advancement, we could improve this obstructive sleep apnea in many individuals. And we started introducing orthodontics along with the adenotonsillectomy. But in 2011, we realized that even this had a lot of limitation. In spite of getting both these things done at the best of centers, we still could not get rid of the pediatric OSA. Then in 2013, the awareness, Gilly Malott, the father of pediatric OSA, as I would consider it as, started writing a lot of articles on how it is essential to establish a good tone and posture in the orofacial structures. So it's something like physiotherapy of the orofacial structures. It is the abnormal posture, the abnormal tone of structures like the tongue, which are so very important. And we did realize that there are about 20 dilators or 20 dilator muscles of the airway in the upper airway, which are so very essential, and out of which the genioglossus has been given maximum importance. And there has been so much of study on it. And we also realized that if you could do a myofunctional therapy or physiotherapy of these structures, along with adenotonsillectomy, along with orthodontics, and you had a multidisciplinary approach, and if you could teach these kids that nasal breathing is something which is most important, that we have now started educating people with yoga and pranayama, we now understand that all this put together only can get rid of an OSA. That means OSA is multifactorial. It is not just an intrinsic obstruction. There is a central play, there is an extrinsic obstruction, there is a ventilatory mechanism going on, there is a chemical mechanism, a mechanical receptors. There are so many things, genetics, environment, everything which is involved. And today I'm just going to present you a case which will just tell you one aspect of it. And this I thought I needed to speak on for the simple reason that whenever I go to a session, when I look around, I see almost more than 50% of people doing mouth breathing. They have their mouths open. And you can see it for yourself when you go out. And why I'm trying to emphasize on this is there is a big difference when you breathe through your nose and when you breathe through your mouth. And why in the pediatric age group? Because the pediatric facial bones, especially things like the maxilla and mandible, are extremely malleable till 15 to 16 years of age. So this is the time when you teach things right, lips sealed, nasal breathing, and tongue on your palate. And this goes a long way. So the case is basically to demonstrate the necessity for these things. My name is Sridhar Ganapathy. I did a small stint in pediatric sleep medicine under Dr. Arthur Teng, and that was a true eye-opener. And I was so fascinated by sleep, but the amount of money that was required at that time to establish a sleep unit was phenomenal. So I couldn't do much on this front. But what is important in sleep is sleep hygiene. So if you could teach sleep hygiene, if you could pick up a sleep disorder which can be done by just historical data like bears or stop bang, or you have a lot of questionnaire which have now come forth, which are pediatric based. And if you could, this is something that has to be done at the reception level itself so that you save a lot of time. And this is something which is linked to everything possible. And once you read about sleep, your interest in sleep would definitely go up. And I'm here only to rationalize medicine for you to think, to generate some interest in pediatric sleep medicine. So this case is going to illustrate the domino effect in obstructive sleep apnea syndrome. So most of us tend to neglect a noisy breathing, be it a viral upper respiratory tract or be it an allergic rhinitis. What we basically feel is, okay, you control the upper respiratory tract etiology and the noise is controlled. But if you allow this to go on, a noisy breathing can lead to a proper snoring, and this can lead to an upper airway resistance syndrome, which can further lead to an obstructive hypoventilation and a frank pediatric OSA. And this is something that I'm going to demonstrate in this particular case. And you need to understand that even snoring, which is going on for a long time, and we basically felt that if it is a snorer without any drop in the oxygen, you could leave them alone. No, it's not so, because any vibration that goes on for a very long period of time can end up with a neuropathy of the palate and can even have distant effects on the pharyngeal wall and the tongue. And there are enough studies to show sensory neuropathies and also alteration in the A delta fibers in the palatopharyngeal lingual complex. And this can have an effect because the tongue is a very important structure, the genioglossus, especially in keeping the airway open, especially in sleep, because the tongue is modulated by chemical and mechanical receptors, and in non-REM, so it plays an extremely important role. So this is a case wherein I'm going to show you how this child with a nose block had mouth breathing and developed a noisy breathing. And I thought this is the right time for us to put a full stop, because this could progress to an upper airway resistance syndrome with progressing to an obstructive hypoventilation to an obstructive sleep apnea syndrome. So this was a 9-year-old girl who was referred to me for fitness for anesthesia. And it was the ENT surgeon as well as the dentist. Both had sent me a letter from an institution that they needed fitness. And when I looked at this girl, it was very obvious that she had mouth breathing. You can see her mouth open. And when you look at her eyes, now see, this is when you look at her eyes, usually you don't see the conjunctiva beneath the cornea. Now you don't see this at the level of the limbus, okay, because it's usually covered. This is basically because of hypotonia of the face. This is a classical adenoid face, wherein a little bit of the conjunctiva is seen beneath the limbus on the lower pole. You can also see that there is dental crowding. You can see a little bit of dental crowding, especially in the lower alveolar arch. And what I've shown you on the right side is almost kissing tonsils and a uvula also, which looks very prominent. And the dentist also wanted to rectify the overcrowding and the overlapping. And you can see that not only is there overcrowding, overlapping, but you can also see a high arched palate. And I needed to go through the complete historical data in this girl. And like my teacher, Dr. Amdekar, always teaches me that you need to understand the problem before you treat. ENT had already taken an X-ray to show the adenoids and the tonsils impinging on the airway. Though in medicine, we are taught that this is a dynamic process, so an endoscopy is a better modality to show obstruction of the airway and not a static plain X-ray. But all the same, this is to convince the patient, yes, the size of the adenotonsillar tissue is quite big and it is having an effect on the airway. And he has shown this. He has also taken a photograph of the kissing tonsils, and they were pretty convinced that, yes, this needs to be removed. He also convinced them that if this was done, the child would grow. Now, the story about the adenotonsillar tissue is that it grows in the first few years. And after 9 years, it starts regressing. And that is why I find a few of my colleagues from the ENT department very enthusiastic in getting rid of the adenotonsillar tissue at the earliest. I'm talking on this issue because later on I may show you a slide about the controversial aspect about knocking out the adenotonsillar tissue. Now, the dentist who had seen the overcrowding as well as the overlapping and the high arch palate had convinced this patient that the craniofacial aberration, so you can see this overlapping, you can see the high arch palate and the narrowing of the nasomaxillary unit. He had convinced them that this craniofacial aberration should also be rectified. But there were two dentists whose opinion were taken. And one was of the opinion that he would remove one of the premolars to create space so that he can push all these teeth in the right place and give a good arch, which is again controversial, and I'll tell you why it should not be done. So when I went through the complete diagnostic proforma, this child started off as allergic rhinitis 2 years back and had tried out all types of medicine, was given Montelukast, levocetirizine, had gone to an Ayurvedic physician who had prescribed ghee on the nose, had done a little bit of yoga in between, had taken some homeopathic pills, and had tried all forms of medication but had not undergone any skin test or immunotherapy and was not educated about allergens, getting rid or avoiding allergens in allergic rhinitis. And they wanted a shotgun therapy that would put a full stop to allergic rhinitis. So this girl had clear-cut allergic rhinitis. There was a family history of allergy, and even the younger sib also was suffering from allergic rhinitis. So this girl had malocclusion and adenotonsillar hypertrophy, in addition to mouth breathing and noisy breathing. And when we took history and we did a general examination, we did also find that there was the growth centiles way beneath the growth centiles for age, and there was growth failure. And the child also had bedwetting and was hyperactive. And the first dentist whom she visited was basically for caries, which is pretty common in all these children who have allergic rhinitis and who have mouth breathing. And this is one comorbidity which we need to look in all kids with allergic rhinitis. So like I told you, the most important thing in treatment is you need to understand to treat. You have guidelines that guide you. You need to have a working diagnosis before you pen or before you write a prescription. And you need to understand in great detail, and for this you require a very good historical data, and what is most important is you need to listen to the patient as well as to the parents. And when we took the historical data, we found that this child was thumb sucking, had used a pacifier, had this running and blocked nose since the age of 3, was mouth breathing, though they didn't realize it. And the mother was very insistent on telling me that this child had a nice round face. She kept showing me the photograph and said now the face has become long and lusterless. And this child was hyperactive and had a few episodes of bedwetting every week. So why this historical data was important is because even thumb sucking and pacifier can lead to craniofacial aberrations. Today in medicine, we have evolutionary medicine, we have iatrogenic medicine, we have preventive medicine, we have acute medicine. When you take evolutionary medicine, that's what I'm going to be discussing in the next few slides. We do know that it was in the agricultural era that we started getting caries. And we now know that it is in the industrial era that we are getting malocclusion, which is so pretty common. So ever since the bottle came into play, the bottle feeding, the pacifier, the thumb sucking, we started seeing this crowding as well as overlapping, and we also started getting impacted molars. And we also noticed that acute medicine is like a Pierre Robin who comes with a small chin, whose tongue seems to be falling behind. He's getting an obstruction of the airway and something has to be done acutely. Whereas if you take preventive medicine is what I'm going to be discussing, like vaccination, like immunotherapy, that is preventive medicine. And iatrogenic is, these are the kids who are on all types of inhalers. And if they take a sympathomimetic inhaler and it keeps hitting the septum, you may even end up with a perforated septum. So that is iatrogenesis in a big way. And when we did look at the physical signs, the specialist had already written notes on the adenotonsillar hypertrophy, and the dentist had already mentioned about the caries and dental crowding. Fortunately, this baby's vital parameters, which includes blood pressure, was normal, and even the cardiac evaluation was normal. But we need to understand that anybody with a long-standing allergic rhinitis, with an obstructive airway, with a snoring, wherein the chances of this sleep disordered breathing going on for a long time is there, it's imperative to do a cardiac evaluation to see that there is no evidence of PH, because these are the kids who tend to crash soon after an adenotonsillectomy, and they have to be done in a tertiary center. In addition, other than the ENT writing on adenotonsillar hypertrophy, allergic rhinitis, the dentist writing about caries and dental crowding, adenoid facies were very evident, and there was very evident growth failure. So we do know that when your nose is blocked, you need to breathe, so you tend to open your mouth. That is compensatory mouth breathing. And along with compensatory mouth breathing, what follows is compensatory craniofacial modeling. So it's actually a compensatory mechanism that is responsible for the adenoid facies. And now there are a lot of papers coming in 2016 to 2018 on why the lymphoid tissue in the oral cavity is enlarging in mouth breathing. What they basically feel is when you are mouth breathing, the humidification and filtration and the exposure to nitric oxide in the nose is lost. So there is a lot of trauma on the lymphoid tissue. This traumatic insult, along with an infective insult, along with the dry air, brings about an inflammatory response in your lymphoid tissue. And remember that all the lymphoid tissue in the gut-associated lymphoid system are roomed peripherally, so you can also get into an inflammatory state. And this inflammatory state can also give rise to a pro-inflammatory milieu in your system, which is not going to be very favorable. Because today we do talk a lot about pro-inflammatory milieu and obesity, pro-inflammatory milieu and psoriasis, so that they are all not just skin deep, they need to be treated systemically. So the distant effects of nose block has been shown in cognition, has been shown on taste perception and taste bud degeneration, has been shown on tongue posture and tone of the tongue. We need to understand that the tongue has a lot of intrinsic and extrinsic muscles. We were just talking about the genioglossus, but you could have one that is attached to the hyoid, geniohyoid, one to the styloid, one to the palate, and so many intrinsic muscles. And they are basically, most of these muscle bundles are the non-fatigable muscle bundles. So the tongue is unique, and that's what we are going to be talking about, the posture of the tongue and the tone of the tongue, and how a compensatory mechanism, if it is stretched beyond a particular point. So this is how, like the way my teacher always, Dr. Amdekar always used to say, that if you stretch rationality in medicine beyond a certain point, it becomes irrational. And that ignorance does not mean facts don't exist. So the complete reason why I put forth this case is just to create awareness, just to make you think and not to teach anything. So the compensatory mouth breathing is because the nose is blocked, so you need to breathe through your mouth. But what happens when you breathe through your mouth is, one, the conditioning effect is lost, humidification is lost, there is no filtration, and there is no nitric oxide treatment of the inhaled air. Also, when you breathe through your nose, it is seen that oxygenation is better, there is less carbon dioxide washout, and the ventilatory mechanisms, what is known as the physiological ventilatory response, is better tuned to nose breathing rather than mouth breathing. So there is a disadvantage when you breathe through your mouth. But we know this is compensatory. But if you allow this compensatory mechanism to get into a habitual state, that is, you don't intervene early, then what happens is you end up with craniofacial aberrations. So let me show you how you get these craniofacial aberrations. So it started off with allergic rhinitis. So in an allergic rhinitis, you have mucosal edema, you may have turbinate hypertrophy over a long period of time, you have all types of cytokines, you have all types of inflammatory cells, you have epithelial cells playing a role. You could have a local atopy called as entopy. You have leukotrienes coming into the picture. So initially you may have a runny phase, later on you may have a block phase, and that is the phase when you don't seem to give much importance, but the patient is terribly disturbed. The mother says this baby is not sleeping. The same thing happened with this 9-year-old girl. The mother said that she always loves to sleep in the prone position. And we'll come to this later on, why the prone position, or she's more comfortable when she lies down on the lateral side. So the lateral as well as the prone position allowed her to sleep well. And the mother also complained that the bed is in a total disarray in the morning when she gets up. That means she was not sleeping well. So she was noisy, not sleeping well. She had an abnormal posture, a hyperextended neck, prone position preferred, lateral position preferred, and she was bedwetting. She was hyperactive in the day. She had adenotonsillar hypertrophy. She had a nose block. She had nasal nose block. She had a nasomaxillary complex wherein the maxilla was narrow. It was a high-arched palate with overcrowding of teeth, everything pointing towards an upper airway obstruction and a sleep disordered breathing. So let's look at the nasomaxillary unit. So what is colored in the green is the nasomaxillary unit. So if you understand this floor, for it to develop, that is what we talk about the hard palate, for it to have a nice round effect, you require the tongue resting on it. What is most important is the tongue should be resting on the hard palate. And for this to happen, your lips have to be sealed and the tip of the tongue should be just behind the incisors on that papilla, and it should be on the roof of the mouth. So let me show you something very simple. What you do is you close your nostril, and before that what you do is you put your tongue on the palate. So rest the tip on just behind the incisors on the papilla, and then suck it up. Now close your nostril. So your tongue is up, your nostrils are closed, try to breathe. You cannot breathe. So this sort of a posture wherein you have a tongue resting on the roof and you mouth breathing allows for an optimal development of the nasomaxillary unit. And this is very essential. Now, if the tongue is not occupying the palate, the tongue gives support so that gravity which pushes the palate down is pushed up by the tongue. And the tongue supporting the palate also prevents the buccinator from exerting too much of pressure on the lateral pressure on the face. So here you have the buccinator exerting pressure on the lateral side of the face. You have gravity pulling it down when your tongue is on a low position. And this low position and a little bit of posterior position is usually seen in mouth breathers, because they mouth breathe because their nose is blocked. And if your nose is blocked, your tongue has to be kept in a low position and a little bit also posteriorly to allow for air to get in. So this is not a good posture because this does not develop well. For this to develop nicely, you require the tongue sitting up here. So the absence of the tongue, the unopposed action of the buccinator, the gravity pulling it down is bound to cause a V-shaped high-arched palate and a compromised floor of the nasal cavity. Understand this, long-term implications. Now, if the tongue is bigger than the oral cavity, the tongue will start pushing on the teeth. So there is also a little bit of overbite. And what is happening is it's all a mess inside, and this translates into a mess outside. So that is the reason for the craniofacial aberration. Not only is the aberration seen in the nasomaxillary unit, but you also see a mandible which goes forward, a maxilla which grows forward. Both start growing downward. So when you have a downward swing, the mandibular length is more or less same, but this angle becomes more obtuse. And the resultant, what results in this is overcrowding. And again, you have a wisdom tooth which is going to be impacted because of overcrowding. And this is what we see. So what is happening is you are getting a long face, you're getting a flat face, and because the tongue is also placed down for a very long period of time, and it has lost its original position and has lost its tone, it's not as efficacious as it usually is. So these are all having long-term implications. And let me just show you a little bit on OSAS. You need to know that when you talk about the airway, you have a nasal segment which is rigid. You have a tracheal and lower segment which is rigid. So you have two rigid segments and a collapsible segment in between. And in this collapsible segment, you have fat, you have adenotonsillar tissue, and you have the tongue. So you have 1, 2, and 3 things sitting here. Plus you can have fat here and you can have other things which could press from outside. And this P crit is very critical. So when you have a negative pressure, suppose you have a nose block up here, you have a nose block here, and you have a negative pressure, and you have a tugging pressure from here by the diaphragm, this is going to collapse. And in addition to collapsing, the collapsible segment of the pharynx collapsing plus an intrinsic obstruction, this is going to be a mess. And it is more of a mess in REM sleep because REM is the sleep wherein you have the body is paralyzed, you are atonic. So REM is when you dream and you are atonic. So in the initial phase of sleep, it is non-REM, and towards early morning, you have a lot of REM, and REM is when you dream, and that is why you can't enact your dreams. So when you're falling from a tree and you suddenly wake up with a fright, it's basically because you are atonic and you cannot function. So in the atonic phase, these obstructive events become more prominent, especially in the pediatric age group. So what you need to understand in this girl is the unfavorable disposition of the tongue and the lack of tone in the tongue, as well as the disposition of the mandible because of mouth breathing. The nose is blocked, the mouth has been used as a conduit for the air, and the resultant habituation, because there was no rectification of the problem in the nose, has resulted in a tongue and mandible being pushed behind, and in a tongue not being very efficient as a dilator to keep the airways open at night. And this is what I was talking to you about Gilly Minault, who I'm a great admirer of, and who has a lot of studies on sleep. He's considered as one of the pioneers in pediatric sleep medicine, and you need to read about this particular article on the polysomnography and non-hypoxic sleep disordered breathing in children, because you need to understand that it is not just hypoxia, it is even the repeated arousals which bring about an autonomic dysfunction which could have a gross detrimental effect in the baby. And see what all can happen. So you have a mouth breathing which gives rise to a local inflammation, which gives rise to tonsillar enlargement. This I already discussed, that mouth breathing is unfavorable because the conditioning effect of the nose is lost. And the repeated trauma to the lymphoid tissue is also one of the cause for inflammation and enlargement. And along with worsening of the poor nasal breathing and increase in upper airway resistance, this I forgot to tell you, you have postural maladaptations. If you take a good history, these kids have a little bit of, they have this thrust because they are trying to keep the airway open. And this sort of a postural adaptation is very common because you need to understand that the fascia from the tongue is connected right up to the toe. So the complete posture depends on mouth breathing. You rectify mouth breathing and you rectify posture. Unbelievable. A small thing can make so much of a difference. Just like you rectify the nose, The eye becomes okay, the hearing becomes okay, your dentition becomes okay, your speech, your swallowing, your sleep, everything is rectified. And there is systemic inflammation, which I also told you, because galt is related to everything. That's the biggest lymphoid tissue in the body. And the abnormal orofacial growth is also basically linked to this mouth breathing. So this is an excellent article. You need to read about it. And even if you go into YouTube, you read about MU, the YouTube on craniofacial dystrophy. It's an entity called as craniofacial dystrophy, a very um, disputed and controversial entity by Dr. Mew and his son, both being dental surgeons. And though we do know that craniofacial aberrations, you have the environment, you have genetics, you have so many other things interplaying, but one of the causes mouth breathing, which can be definitely prevented. So in this kid, if you read guidelines, they would teach you treat allergy. This is as good as telling a patient salt restricted diet. Now, when you don't know the allergen, it becomes very difficult to treat allergy. And even by doing an allergen test, you find multiple allergens. And the response to therapy is also a big question mark, because you have so many mechanisms of allergy. So you have an anaphylactoid individual, you have an anaphylactic individual, you have entopy, you have atopy, you have allergy at the level of the epithelium, you have the Th1, you have the Th2. There are so many immune limbs making a mark on allergy. So we do give intranasal steroids, we do give intranasal antihistamines, we do sublingual, we do immunotherapy. For the collapsing airway, we do use positive airway pressure. And for the obstructed airway, you have the dentist doing orthodontic procedures like a maxillomandible extension or a maxillary extension or a maxillomandibular advancement, or there may be surgeries done on the palate. So what is very essential to understand here is you need to do a drug-induced sleep endoscopy. And we initially used to do it with propofol. Now we do it with the DMD, the new ones, the dexmedetomidine. And these are drugs that don't cause collapsibility of, they don't aggravate the collapsibility of airway. You create a sleep-like state. You pass in a scope, and you require a person who's well-versed in endoscopy. And in drug-induced sleep endoscopy, you try to find out the various levels of obstruction. This girl underwent a drug-induced sleep endoscopy, and what they found is it was basically the tongue that was falling back, and the mandible also, which was retrognathic, that was responsible for blocking the airway. Not only that, what was assessed by the dentist was the narrow maxillary floor was responsible for the compromised nasal function. So what was planned out here was a maxillary extension along with a myofunctional therapy to bring back the tone of the tongue. Myofunctional therapy is nothing but a physiotherapy of the tongue and the oromyofacial structures. So you strengthen the lip, you strengthen the buccinator, you strengthen the tongue, you strengthen all the muscles in the oromyofacial structure. And if you do all this together along with an adenotonsillectomy, the success is much more than just doing an adenotonsillectomy. Because here we have realized that the problem is the tongue falling back, the mandible being right back, in addition to the adenotonsils and the nose, which is in a totally compromised state. So what I wanted to emphasize on is we have forgotten the muscles. 20 dilator muscles. And the most important out here is the genioglossus. And now we have a new modality of treatment wherein what we do is we use a pacemaker. So when we know that it is the genioglossus which is failing, because genioglossus is one muscle which can be activated by a collapsing airway as well as a chemical impulse. So when you have a building up hypoxia or building up carbon dioxide, or when the airways are collapsing, that is the time the genioglossus is stimulated and it helps in dilating the airway. So if you have a sensor that can also sense and stimulate the genioglossus, it would go a long way in patients who could be treated this way. So now we do have a pacemaker also, which is fitted in like a cardiac pacemaker, which stimulates the genioglossus whenever the upper airway collapses. And it is being used in a number of patients with OSA with a lot of success. So this is another article which I want you to read, because these are scary things. Because what I was trying to tell you is, just like we do know it is multifactorial, the genesis of OSA, we should also know iatrogenic medicine. So we do know that histamine is a neurotransmitter. Histamine is needed for cognition. Histamine is needed for neurotransmission. So using an antihistamine is scary, because for awakefulness also you require histamine. So when you use a first generation antihistamine that crosses the blood-brain barrier with so much of side effects, you need to understand that yes, all your medicines come with collateral effects. So the same way, this article is on a positive airway pressure. So what we did in histamine is we started using local antihistamines in the form of azilastine, olapatidine, and there are many more which are coming our way. And in fact, we are also using some new generation ones like ibastine, because we do know that the mast cell and degranulations are nowadays very, very famous. Even they have a role in functional GI disorders. So when you talk about iatrogenic medicine, what they did find is, when they did follow up kids who had taken positive airway pressure, they did find that there was the mask, the positive airway pressure did have changes in the midfacial and dental structures. And this is not surprising, because it is in the initial few years, that is, anything that has to be done on the midface, we don't do till the age of 16, sometimes till the age of 18, because this is the time the midface and the dentition are growing. So when you have all these growing, you don't fiddle. And this particular article makes you think twice before even using a positive airway pressure for a long period of time. So that's number one. Number two, I did mention about another dentist who thought of removing the premolars and putting the dentition in line. That is not going to help, because the problem is you need maxillary extension. You don't require them to be put in line and just change the appearance, because that is not going to be beneficial. We need to increase the floor of the nasal cavity. So this is one that was scary. This is even more scary. This is a study which came in 2018 with a large population, and a very well done study in which they showed that long-term risk of allergy, infectious disease with removal of adenoids and tonsils in childhood. And I think you need to go through this so that the next time, that's why I do see a lot of my colleagues in the ENT department doing partial tonsillectomy, partial adenoid, but with the risk that it may grow again. So we need to understand that everything comes with collateral damage, and we are in an era of personalized medicine wherein we need to consider what is to be done in each condition. So each individual has to be considered individually, because it might be different exposome, different genetics, not only different exposome and genetics, but also the economical aspect, and based on their craniofacial aberrations, we need to tailor make their therapy which suits their pocket. And this was another thing that came in 2013, and we have had a number of articles coming in 19 and 20, wherein the critical role of myofacial re-education has come in. So whether you're doing a tongue tie, whether you're doing any craniofacial surgery, craniomaxillary surgery, it is imperative that you start education prior to surgery. So you need to re-educate before you do surgery and continue re-education, because the problem is there is an underlying myopathy, there is an underlying neuropathy, there is an underlying postural aberration as well as a tone aberration. So if you want to put all these things in place, you need to start before you get into the main forms of therapy. And only where this has been done along with the main procedure. So where we have used CPAP with myofascial re-education, where we have used adenotonsillectomy along with myofascial re-education, we have got great success. So this has come to stay. And this, again, I think all these are free access, 2018 article, wherein nasal breathing is given importance, because if you want a craniofacial and airway development, because now everything has become airway centric, be it ENT, be it pulmonology, be it dentistry, everything has become airway centric, be it pediatrics. And if it is airway centric, nasal breathing has been given maximal importance. We do know that if it is genetics, you can have craniofacial aberrations and syndrome. I'm not saying so, but I'm talking about those craniofacial aberrations like the one that I presented in my case that can be prevented by changing from mouth breathing to nasal breathing very early, and by teaching them physiotherapy of the orofacial structures, which is very imperative. So lips sealed, tongue on the palate, and nose breathing like this little one is doing. Breastfeeding, very important. Thumb sucking and the pacifiers need to be out. Teaching on diet, the soft diet also has contributed a lot to the nasomaxillary unit development, because when we used to be during the hunters era, we had those solid masseters and pterygoids. Now all our muscles in the facial structures are not to the same extent as it used to be in that era, and we have been losing face. Mark my words, underline the statement, we have been losing face over the years because of changing exposome and the way we live. So this physiotherapy of the myo-orofacial structures is what is called as myofunctional therapy, and I find that most of the sleep consultants also are not giving much importance to this. This and an endoscopy should be given prime importance before you venture into any therapy, because you need to know where the obstruction is. So it might be obstruction at multiple levels. So you need to be tackling obstruction at multiple levels. And this aberration in neural and motor, which usually accompanies most of these OSAs, can be rectified by a good myofunctional therapy. But the success rate has been seen usually above 5 years of age, though this has been tried right from 3 years of age. These exercises are extremely simple, meant to be done about 6 to 7 times minimum per day. You require an involvement of the family, and you have a number of YouTubes which show the way it has to be done. There's not much of expenditure, and I'll show you some of the exercises towards the end of the session if time permits. So as this photograph demonstrates, yes, the tongue needs to be brought into the right position, as well as it has to be got into the right tone, and this requires exercise. And what does the genioglossus do? It does the following things: thrust, retraction, up and down. So what you need to do is, all that you need to do is thrust your tongue out, touch the tip of your nose, make an effort, try to touch the tip of your chin. And this has to be done a number of times. Then you try to take the tongue up to touch the papilla between your incisors. Keep it in that position. Try to stretch out your tongue for as much time as possible. And you can also do this. That's another way. So these are very simple tongue exercises. There are a number of exercises, because you need to understand that even the buccinator plays a role on the lips. So suppose you want to make all these grimacing movements, you need not only the orbicularis oris, but you also require a risorius, which we have never heard of, and even the buccinator plays a role. So this is for the buccinator. This is also for the tongue, where you are pushing against the cheeks. So it is something which is very simple. Simple things that the tongue does, you need to re-educate. So if you re-educate, there is a re-communication, there is a re-establishment of contact with the upper centers, there is the neural network and the motor network is re-established. Now I'm going to show you some clues in the oral cavity that should make you aware that this patient is going to be a candidate for an obstructive event. A tongue tie. How many of us make an effort when if the newborn to look for a tongue tie? This is obvious and this is easily picked up. Most of the tongue ties are picked up by the mother and she comes and tells you. And most of the tongue ties may not even have difficulty in swallowing. This is also a tongue tie. See the dimpling out here? And this is because of a posterior attachment. So this also requires treatment. This requires treatment. And in all these conditions, what you require is you need to do oromyofacial therapy to begin with, and then the tongue release. And this has to be done by a person who knows all about tongue release. It is not as simple as taking a scissor, going in there, putting two sutures up and down and cutting it. It's not so. You have measurements, you have a range of motion, you need to understand what you are doing because you don't want fibrosis and you don't want the treatment being worse than the disease. A high-arched palate with overcrowding, we already discussed. Yes, there is a problem with the nasomaxillary unit. It is a crowded nasal cavity. You may have aberrations inside the nasal cavity, like the septum, like the turbinates, all being haywire. So you need to probably expand this maxillary unit. And here you can also see the accompanying caries. So when you find caries, you check for mouth breathing and just don't stick to sugar. This is pretty obvious, the kissing tonsils. And here on the other side, you can see that the uvula is definitely big. And this may also, during your drug-induced sleep endoscopy, will tell you, yes, if the uvula is causing a problem, you need to understand that vibrations can itself lead to neuropathy and myopathy. Again, mouth breathing can have gingival effects. Can you see the gingival hyperplasia out here? This gingival hyperplasia gives you a telltale, this tells you that yes, this is mouth breathing. And the same way here, you're trying to accommodate the tongue between your dentition. That means there is a disparity between the size of the oral cavity and your tongue. So because the tongue is not able to fit well into the oral cavity, you are trying to push it between and you are trying to push the teeth in front. So if you find this sort of a posture, if you find gingival hyperplasia, again, you need to think. Again, the imprint of the teeth on the tongue. See this? So when you get such imprinting, you know for sure, yes, there is a disparity between the size of the tongue and the oral cavity. This is something like a cephalopelvic disproportion. And this is pretty obvious, a huge tongue. So a big tongue, be it a Beckwith-Weidman, be it hypothyroidism, be it a storage disorder, you need to reduce the size of the tongue. So the treatment modality is going to differ. This is something which I thought I should discuss. You have a lot of mothers who come and tell you कि मेरा बच्चा रात को दांत काटता है. This is a bruxism. So when you have bruxism, one is a psychiatric. I mean, it's actually, you tend to have a lot of things that you intend to do, but you're not allowed to do that suppression of, that is anxiety, and it's basically a psychological problem in a very small percentage of case. But usually this is equated with worms. And when you look at the oral cavity, if you find erosions, dental erosions, or if you find abfractions, you know for sure that this is long-standing. This can have effect on the temporomandibular joint. This is another thing which I forgot to mention. When you have a nasomaxillary unit which is disturbed, the mandible which is disturbed, you can have recurrent jaw pain and neck pain and shoulder pain because of also alteration of postures and alteration of the temporomandibular joint because it's a hinge joint. So when you do see this, you need to understand that bruxism is a way of telling your oral dilators to wake up. So when you do bruxism, it's actually a way of using your oral muscles or oral dilators to open up the airways. This is the intraoral checklist that we usually have in our proformas other than the sleep questionnaire. So the sleep questionnaire that we usually use in the pediatric age group is the BEARS, very easy to download, BEARS, just download, read about it. You also have the other long questionnaires which can extend up to 12 to 18, but you need to ask about when does he go to sleep, when does he get up, how's the state of the bed, does he have bedwetting, is he too sleepy in the day or is he too hyperactive? Always remember, daytime sleepiness, which is so common in adults, is not so common in children. Children are hyperactive. So even in Australia, when I was doing sleep, I was a part of a study which Dr. Arthur Teng was doing on attention deficit disorders, wherein he found that rectifying sleep could really have a big role, and even most of the drugs like atomoxetine, which is used, may all be working through the sleep mechanisms. So you need to have a questionnaire. You need to look at the oral cavity for kissing tonsils, for these Malampati score with tongue thrust out and with tongue in the oral cavity. You look for that imprinting of the teeth, what is known as a scallop tongue, which will tell you that there is a disparity between the size of the tongue and the oral cavity. You look at the mandibular arch and the maxillary arch. You look at the bite, whether it is in front or behind, the malocclusion. All this will give you an indication, yes, there is a sleep disordered breathing. And also most of these kids who get up with a sleep disordered breathing have a dry throat in the morning, and they even complain of odynophagia. So if you have any kid who talks about painful deglutition, which is restricted to the morning, it's usually mouth breathing, and he probably has a nose block, and he's using his mouth to breathe, or there is an upper airway obstruction, and you need to look into it. So these are the four main components. Collapsibility, we take care of airflow. Dilator muscle, there is a compensation. Arousal, arousability, chemosensitivity, instability. But what we need to know here is, even though there is a surgical thing here, this needs to be tackled. Easy way of doing it, and it is an adjuvant to all therapies. And if you do this, it is as synergistic with all other modalities of therapy. And what is new in sleep medicine? Now you have a NIT camera, you don't have to be wired. And this is a camera which is attached to an artificial intelligence based on your movements, based on your respiration. It has a scoring system that can tell you whether you have a sleep disordered breathing or not. Still, they are working on it. It's an amazing thing that all that you need to do is sleep on a bed with the multiple cameras, and it has this Snapdragon 410E processor, and there are a lot of case studies coming in, and it's found to be fitting in with the normal PSGs that we do. So even when you do a PSG, there is a polysomnography, you need to do a polysomnography, you need to do an endoscopy, and you need to do a polysomnography with positive airway pressure to titrate what is the right pressure for your kid. And this is the device that I was talking to you about, a pacemaker, which is connected to the genioglossus. And whenever there is a collapse of the upper airway, this will stimulate the genioglossus, which will again cause dilatation of the airway. And this has been found to be very, very useful. So this is just one part of sleep. And what gives us sleepless nights is basically stress. We need to understand that we cannot escape corona, but it is more sensible to stay indoors now because there is no availability of beds. So it's better to stay home, stay safe, not get stressed out, eat good food, sleep well, keep away from blue light, so that all your equipment should have that device which converts blue into yellow light or something towards the other spectrum that does not affect melatonin. Even in the house, post 4 o'clock, you should have the smart lighting wherein you don't have light that affects melatonin, and you need to disconnect. If you have too many tabs open, it's going to cause a sleep disorder because the sleep cycle comes in 90 to 120 minute cycle. And once you miss the boat, you have to wait for the next boat. That's why it's always better to go to sleep reading a book, because you can close the book and read the next day. Whereas if you're watching a movie, you need to know what happens in the end. Whereas even if you're a hyperactive kid, you could still open the last page, know what happens, and then sleep, whereas with a movie, it's not possible. Thank you so much for a patient hearing. My teacher in sleep always used to tell me that money can buy you a pillow, money can buy you a bed, but you cannot buy you sleep. So you need to do good to others, stay home, stay safe. Thank you so much for a patient hearing.
Thank you, sir, for wonderful presentation. Now the session is open for the question and answer. So I request all the delegates, please ask the questions. Sir, here online we received the few questions.
I thought I should first discuss one question which was very interesting, which was put forth by Dr. Hemant Joshi, one who does so much of community pediatrics, and he has some brilliant answers like Ganga Jal for loose motion, and I am a big fan of his. He told me that his sleep has improved ever since he started delivering lectures every day. And he wanted to know if there was a correlation between talking a lot, sleep apnea, and getting a good sleep. And only thing I could think about is when you are talking a lot, you are using your orofacial muscles. You're getting toned up. You're using everything right from your lips to your tongue. So there are some which are purr, like purr by the lips, tur by the tongue. So you are using every possible muscle in your orofacial cavity. So you're getting back your motor and neural system back connected to your upstairs, which you would usually not be doing, because in a heavy OPD, we talk very little. We keep writing, we keep listening. It's our assistants who do most of the talking. Though I know with Hemant, it's not so. He has many tricks up his sleeve. He has some tricks in his pocket. He has peanuts in the pocket for kids to improve their nutrition. And I thought this could possibly be a reason that you are exercising your orofacial structures, and probably that's how you are keeping your airway open at night, probably not getting your obstructive events and sleeping better.
Right, sir. Sir, there is a question from Dr. Matthew PL from Kottayam. He's asking sequelae in case of hair lip, left of midline plus cleft at upper gum level.
I didn't get him. Is he talking about an air leak with a CPAP machine?
Sir, he's asking about the sequelae in case of hair lip.
Yeah, air leak can be anywhere. So he's probably talking, and you continue with the same thing. Complete the question. Air leak.
Then is left.
Then read out the complete question. Read out the complete question.
Sequelae in case of hair lip, left of midline plus left at upper gum level.
I just didn't get his question, but let me tell you, there are other sequelae for a positive airway pressure. See, when I was in Australia, I happened to meet Dr. O'Sullivan, who's the discoverer or the inventor of the CPAP machine. An amazing lab, a simple person who took him to his lab, and I was like an intern. But even then, with so much of enthusiasm, he showed me his complete lab. The biggest problem with the CPAP at that time was air leaks. So you had air leaking from the side, which caused dryness of the eyes, caused dryness of the face, and had a lot of issues of compliance. So they started manufacturing custom-made face masks for kids. So they would come to the lab and they would take measurements like a tailor and make a polyurethane mask, which would fit it onto the CPAP machine. That was amazing. I don't know what his question is, but since he stimulated me with the palate, I had to tell you one more thing is, children who have had a cleft lip, cleft palate, and who have been operated, again, there the neural and motor integrity is slightly on the lower side. They are also a candidate to sleep disordered breathing, and they have to be followed up. You should also look at lip seal. So it's not just tongue tie, but even a lip tie has to be examined. So lip ties and tongue ties can also predispose you, because you don't get the optimal position of the tongue on the palate. You need the tongue on the roof of the mouth to support your palate. If you support your palate grows well. If your palate grows well, you have a good floor of the nasomaxillary unit. So even aberrations like a deviated septum or an abnormal enlargement of the turbinate on one side, everything is avoided. And the problem of nose plug is also on the lower side in case of a cold. Matthew can ask me again. I'm sorry, Matthew. I just couldn't get your question. You could ask me again. Yes, Dinesh.
Sir, there is a question from Dr. Hemant Thane. Will sleeping in prone position help?
Yeah, so again, I forgot to tell you about why this girl was sleeping in the prone position with a hyperextended neck and why she was also fine sleeping on the side. So whenever you get a history from a patient that they are more comfortable this way, that is an indicator that your tongue and your mandible are falling back. Now, this prone position has become very famous in the corona epidemic because we knew this long time back that sleeping in the prone position gives you an airway which is more efficient than sleeping in the supine position. So we did know this. So there was a time when I did my neonatology where we were told that baby should be put in the prone position for resuscitation. But then this went off and then it went into the supine position, then into the lateral position, and positions are still changing with sudden infant death. Now, one of the reasons why you do this is because you can prevent the tongue and the mandible from falling behind. And also in obese individuals where the pharyngeal walls are especially thick and big, and also you have a lot of fat in the collapsible segment, you are more comfortable lying down in the lateral position because you don't block the airway in the lateral or in the prone position. You get more space. So you have certain devices in which you tie it around you. So it is like you tie a ball around you so that the moment you lie down supine, because the ball comes in the way, you quickly change posture to the side.
Okay, thank you. Next question is from Doctor from Chennai. Ibastin used in children, doses and safety.
No, it has just hit the market. Don't ask me about this because let me tell you one thing. I am so fond of pharmacology, but my inverted commas in pharmacology is that unless and until a drug has been studied to a great extent, don't jump into it. That is number one. Number two, a drug should be used only in an indication wherein it provides something much better than existing drugs. So we have new generation antihistamines. What I mean is, I'm not talking about first generation, I'm talking about the levocetirizine, which has evolved from cetirizine because it wanted to extend the shelf life. We have fexofenadine, which came from, you need to understand that hydroxyzine became cetirizine, cetirizine became levocetirizine, but the part in cetirizine that works is levocetirizine. Now it was fexofenadine that came from terfenadine. Terfenadine had side effects, prolonged QT interval, so it got converted into fexofenadine, but fexofenadine has a phenomenal safety record, though it does have the P glycoprotein system is affected. So when you're using a drug like rifampicin, you need to know that it can affect the pharmacodynamics kinetics of rifampicin, so don't give it along with it. So you need to understand drug interactions, and I don't think Ibastin provides anything in addition to all this. But there is a new study on functional GI disorders wherein they have now found that there is a relationship between mast cell degranulation close to the enteric nervous system and effects, and in addition to the gut-brain axis. And they are doing a study on usage of Ibastin with ranitidine, and they are trying to see if there is any beneficial effect because they have found this histopathological evidence. So that's why I always tell in medicine, whenever you are asked the cause of a condition, I call it as I. So I stands for, the first one is irritation. Second is itch, that is allergy. Third is immune, I again. Then you have infiltration, all the malignancy. And then comes iatrogenic, and the last is I don't know. Now, I don't know, it doesn't mean everybody doesn't know or it's not there. So it's over a period of time that you get to know. So even in functional GI disorders, even though we know it is that nothing obvious is there, there is a problem somewhere. Just like for atopy, you have local atopy in the nose, which is called entopy. So medicine is evolving. There is no full stop or conclusion. And my knowledge on Avastin and allergic rhinitis, no, I don't know much about it. I think you may have to talk to people who have done studies on it. I think Dr. Nagaraju and my friend Arif from Hyderabad, they were giving a few talks on Avastin and allergic rhinitis. You need to speak to them. But all that you need to know is histamine is a neurotransmitter. Histamine is needed for wakefulness. Histamine is needed for cognition. Whenever you use an antihistamine, see that the efficacy is much more than the side effects or collateral effects, and pick an antihistamine that doesn't get into your brain.
Again, question from Pankaj, Navi Mumbai. He's asking why mouth breathers get dental caries. How to look for entropy, that is local allergy?
Okay, so so if you do, so let me take the first question of the caries. That's something very close to my heart because I am very close to the microbiome. So even in the oral cavity, you have a microbiome. Now, this microbiome is kept under control by a lot of antimicrobial substances that are generated in the saliva. And also the pH of the saliva plays a big role in it. So what basically happens is, always remember that in the genesis of any problem, it is not just one organism, it is a community out there. So when there is dryness, when there is no saliva, when there is no lubrication, when there is no turnover of saliva, when there is no control of the microbial overgrowth in the oral cavity, because the oral cavity is one place where you can have blooms. So what grows very fast are organisms that rapidly divide. The slow dividers are removed by the saliva. You swallow them, they get into your gut, and there the acidic pH finishes them off. Whereas the rapid growers are the ones that grow very fast. And if this salivary flow is stopped, like xerostomia, you have a condition like xerostomia, that is when you get caries. So in the same way, so if you have mouth breathing and you have dryness, there is no salivary flow, no antimicrobial peptides, what is going to happen is there are microbial blooms that favor growth of pathobionts, in which number one is also a Streptococcus mutans. And if you have also a karyogenic environment, what I mean by a karyogenic environment is maltose is least karyogenic. So if the mother is breastfeeding, maltose is least karyogenic. Whereas all the other sugars are very karyogenic, high glycemic index, and a high reward like this thing in the brain. They're all bad. So what basically happens is if you have a karyogenic environment, you have the wrong microbes, you have a pathobiont bloom, and you have dryness, you're bound to get caries. And that is why when you get up in the morning with a dry mouth, you have bad breath. That is an indicator that the volatile organic acids are from the pathobiont bloom. The second question was entopy. What is entopy? Atopy is you have IgE mediated problems. So you do a blood, you have an IgE there. But in entopy, you don't have an IgE. But when you do a study at the local mucosal level, you have IgE. So when you have an allergic reaction, either you can have mast cell degranulation by an IgE mediated or a non-IgE, which is anaphylactoid-like reaction.
So Dr. Hemant Joshi, he's suggesting us a nebulizer and a freeze tank air compressor make a good air source for bubble CPAP in obstructive sleep apnea.
I told you he's all into community pediatrics. He has innovative ideas.
Yeah.
But the thing is, anything, even putting your the vacuum cleaner in the house, that's how Sullivan came out with that discovery, that you keep the airways patent by a flow of air. Now, this flow of air should have a good CPAP, which does not cause CO2 retention. That's number one. And number 2, does not cause too much of dryness. And number 3, it should not be worse than your obstructive event. So if you can manage to do that, it's absolutely great. So you don't want your therapy to be worse than your problem. So again, so the problem here again is you have to pick up a population who require this therapy. You have to do a double-blind, randomized, controlled trial with all possible variables. And then this could be a wonderful modality because it's going to fit into everybody's economics. It's a wonderful thought, yeah?
So there is one more question from Dr. Mudgerikar from Pune. He is asking significance of drooling of saliva in sleep.
Yeah, that has got no significance. Absolutely no significance. In fact, the only part is you have a lot of these retarded children who actually drool more. So when you drool more, usually the parents feel, is my child normal? But I think almost 10% of even the adult population drool. So drool is basically the lip seal. Okay, so you can improve your lip seal. So it's actually a disparity between the buccolingual compartments, the salivary production, the salivary flow downwards, the so-called lip seal, and the tongue movements during sleep. Because it's multifactorial.
So we are done with the most of the questions.
I think thank you so much. Yeah, thank you so much for being there till the end. The only thing is the Matthew's question, I don't think I managed to answer because I didn't comprehend his query. If he has resent his query, if you can read that, just check it out since we have a minute more.
You want to talk about the cleft lip. Cleft lip. We're asking about cleft lip.
Yeah. So this is one condition where you need this oromyofacial therapy very early because there is a problem right from the beginning. That's what I was trying to say. A cleft lip requires this oromyofacial. So I will show you something for the lips. For the lips, you do this like a monkey, pouting, then whistling. So these are two things that are very, very essential for the lips. Even a balloon exercise for the buccinator. You get these balloons when you stop your car next to the signal, those big balloons, you blow onto it. That helps with your buccinators as well as your lungs. There is nothing like breathing exercises in yoga, the pranayama. You need to understand that at a point of time, you're actually breathing only through one nostril. And there is a cycle. And today we need breathing exercise, we need good sleep, and we need good food and good immunity, and we need to switch off because Corona is here to stay and you cannot escape the Corona, but you say hi to Corona when you can get a hospital bed.
Thank you, sir. Thanks a lot.
Thank you, Sonali. Thank you for the opportunity.
I also like... Yes, Sonali.
Dinesh, sir, you can give the vote of thanks.
I would also like to thank all the delegates who took out their time in the Sunday morning and make available themselves for listening this wonderful topic. I would also like to thank my colleague from Alembic, Sonali and Divya for this successful event, as well as I would also like to thank the Mr. Dinesh for this smoothful streaming of this CME. Thank you. Thanks a lot.
Thank you so much, sir. It was a privilege to have you on board for today's session. We had 20 doctors of Nepal also who had logged in, and we are getting a lot of queries. Queries on taking up your video. So what we are doing is we are going to upload your video on YouTube, and we'll share with you all the details of the same so that even your friends colleagues can view it any time of the day. Secondly, thank you all the delegates. We have recorded the registration of 200 pediatricians today for the program. My my sincere thank you to all those doctors who have taken out time for Dr. Sridhar Ganapathy's session today. And it was in fact a very thoughtful and a very case-oriented presentation, I must say, sir. And it really enlightened me as well, because it also sent me a trigger, because my own daughter has a habit of thumb sucking. So definitely how to get rid of that, I would personally be in touch with you, because without that thumb sucking she is not able to sleep. So that is what I could relate through the presentation. Thank you very much, sir. Thank you, Dr. Dinesh. Thank you, Divya, and Dinesh from Digital Infomedia to telecast and broadcast this smoothless streaming of the program on the website www.alembicew.com. And we would connect definitely on 20th May for Dr. Swati Bhave's session also. So requesting all the viewers to stay tuned in for the future sessions on www.alembicew.com. Thank you so much, sirs.